I request Professor Dr. Luke diWitte to make his presentation. Dr. Luke is the president of Global Alliance of Assistive Technology Organization, Research Group Technology to Healthcare, Center of Expertise Health Innovation, The Hague University of Applied Sciences. Dr. Luke will present on on access to assistive technology in rural communities.
I will speak about the role of assistive technology. That is technology that helps people with disabilities or functional limitations to live their life as they want to live it, which is a huge problem. I assume that many of you have seen this very important report of the World Health Organization about, it's called the Global Report on Assistive Technology. And that demonstrates very clearly the size of this problem. It says, well, about 2.5 billion people in the world might benefit from the use of assistive devices. But in some countries, only 3% of these people who might benefit have access to it. In the richest country, it's about 90%, and the average is below 50. And that means that we really have something to do, because we know very well that there is a strong correlation between poverty, hunger, and disability. And assistive technology is extremely powerful to break the cycle of poverty and disability, and because it can enable people to go to education, to find work, to live an independent life, to make a living. And there are some good studies demonstrated that if you, as a country, invest $1 in providing people with assistive devices, the societal return on investment is tenfold. So there is some really a job to be done. And this is a topic that I've been working on with an international group for several years. And I've done quite a few studies, mainly in India, but also in Nepal and Bangladesh. I don't go into details, but an important study was done by an Indian woman who has a severe disability herself, Shivani Gupta, and she wrote an excellent PhD thesis calling Invisible Lives. And that title tells exactly what the problem is. She went into rural areas, into villages, and literally looked for people with disabilities. And I must say, we have found the most terrible, unhuman situations. And that was, to a certain extent, we found some similar situations in Nepal, especially in rural areas, but also in other places. So based on these studies, I've been trying to work on possible solutions. How can we solve this? Because the standard is, of course, trying to copy the models we know from rich countries, but they are all based on highly trained professional staff. And however many people you train, you will never have enough in a country like India, but also the other countries I mentioned, to provide the people with professional staff. So we have to think of different models. So we started a project in which we worked with experts from very different countries and tried to develop models based on known experiences and based on our own research. And we also did a study in connection with the World Health Organization about quality criteria. It's not enough to just say, well, here you have a device. It has to meet certain quality standards. So that we have been working on also with an Indian project leader, Gift Norman, a doctor from a hospital in Bangalore, South India. One of the important things that we found in all these studies, and that is not a unique finding, it's common sense, that it's quite a complex issue. You cannot just throw assistive devices into the community. It won't work. You need, on a country level, you need legislative frameworks. There has to be a law that supports things, that gives people rights. Products have to be available. That's a big issue. And we know what can work, and there are many solutions available, but not everywhere. And in most countries, you can hardly get anything. People have to know what's available, so you need information systems. And you need professional advice. But as I said before, you cannot just build it on professionals because you will never have enough. But you need a system to involve professionals and to give proper advice and support in the provision system. You need service delivery models. You need procedures to make sure that you really get what you need and that it's a solid solution. As I said, you need quality standards, guidelines. There have to be rules on who is eligible for what and what is funded by government or health insurance, or what do people have to pay for themselves. Once you have a device, you also need to make sure that it can be maintained and adapted and repaired when it's broken. Big issue, because that very often is not the case. I've seen many wheelchairs with a broken wheel and just useless. Well, you need a supporting innovation program, health information services. So it is a quite complex thing that you all have to arrange to make sure that people get what they need and that it really works. Well, taking that into account, we think the only way to organize this is through regional assistive technology centers. And not specialized centers, one center for prosthetics and one for wheelchairs, but comprehensive one door one door centers where people can go for anything they would need. But that is not alone is not enough. You will need what we call health navigators in local communities. And that's an interesting thing we have experimented with in a number of villages around the city of Bangalore, but also in a number of urban slums in the city. And we have trained women from these communities who had no medical or whatever training. So we gave them a course of about 2 weeks and trained them to become health navigators. And that's extremely important to have people from the communities because, as one of the other speakers mentioned, trust is a key issue. So we in together with people in the community, we selected these women that might be accepted and might be able to play such a role. We trained them, and they became a kind of first contact with open eyes and ears to look for problems. We started with screening for non-communicable diseases. So initially we didn't look at the assistive devices, but we started, the real basic healthcare issues. And that became a very successful formula. And then I decided, well, now it's time to add this perspective of assistive technology and disability to it. Unfortunately, then COVID came. And the whole project collapsed, basically. I was no longer able to travel to India, but the idea is still really valid and alive. So the idea of this health navigator is that it is someone who lives in the community, is trusted by the community, has good links with this assistive technology center and other healthcare organizations, and actively goes into the community to create awareness, to give advice, information, and to identify people who might need to go to formal services. Because that is one of the big issues. People just don't know. They don't go to all kinds of areas. With a little bit of help, they might find a way in the healthcare system. What we also organized is electronic patient records where all the findings were registered, so that if someone with a problem identified goes to a hospital, the data is available to a doctor or whoever they will see.
Doctor, you have a minute.
Yeah, I know. So how far are we? As I said, we experimented with this. We trained about 15, 20 women. And then COVID made it all collapse. But not only me, but our team, which involves also people from these countries I mentioned, we strongly believe in this model. And I think it's really worth trying it out and rolling it out because it's one of the possibilities to do something without being dependent on high-level trained people, and you make real connections with communities. If we do that and we combine assistive technology with the other healthcare issues that are so important, including the mental health issues that were just presented, you get a model that really operationalizes this concept of universal health coverage. And my conclusion will be let's try to do this and evaluate it at a large scale. So I would hope that our partners among you that are interested in making a next step here. Well, that's what I prepared. Thanks.